Why do we put rheumatic fever on a pedestal and rheumatic heart disease? Well, it's preventable. It's a preventable disease of childhood, primary school age, stretching with a long shadow into adult life with morbidity and premature mortality. It's a marker of poor healthcare access. Penicillin is cheap, and there's a very marked disparity compared to other infectious diseases. Before the primary prevention program announced by the government in 2011 started, the rate of rheumatic fever was going ever onwards and upwards. This is 5 to 14-year-olds nationwide. The top line, the green one, is Pacific, rates per 100,000, and Maori in red. And you can see for Pākehā, it's crawling along the bottom there, almost undiscernible. So the government announced that they were going to prevent first cases of rheumatic fever. Most of the initiatives were taking place in schools. What is the evidence for the prevention of first attacks? Well, in fact, there's not very robust evidence. What happens currently out there in general practice comes from trials in the US Army using injectable penicillin in young adolescent men. And this is then derived to, this is how you treat sore throats with 10 days of penicillin. But it was never translated into a community initiative. So all the trials on this meta-analysis are in Army young men, with the exception of the yellow one, which is a very small and unfortunately insignificant statistically trial in Chicago. Didn't meet statistical significance. There has been a reduction in rheumatic fever in rich countries, the OECD, so Denmark is the prototype at the top there. And an interesting study looking at before and after in neighbourhood clinics in the US in inner city Baltimore, showing that access to neighbourhood clinics seemed to reduce rheumatic fever. So in that situation, New Zealand had no evidence for primary prevention of rheumatic fever at the community level. And the advice at the time was, we're not really interested in putting a lot of effort into this until we have evidence. So from there spawned the school-based trial, which was largely run in counties, but including Otahuhu, starting in 1998. And these school clinics, this is a disease of primary school kids, were to improve access to sore throat management. And it was a new paradigm for delivery of healthcare for this age group, with lay workers doing the throat swabs, the nurses empowered to deliver antibiotics by standing orders, and the outcome was the rheumatic fever citywide register, which new cases were always registered for their secondary prophylaxis. The outcome of this huge trial was actually over 4 years, 80,000 person years, not statistically significant. And it is considered that this is probably because of cross-contamination. Kids could be in a school with a sore throat clinic, but they could have had siblings who were not in a clinic, and thus, within their families, whānau, within the neighbourhood, it's likely that the highly infectious group A strep could spread. To keep moving, we put our trial into a meta-analysis, along with other community trials. Ours is the only RCT, randomised controlled trial. However, with the various community-style trials, it was considered that perhaps rheumatic fever could be reduced in such a community endeavour by about 60%. From the RCT, it was recommended that there were modifications to allow for the issues that I've just raised. So swabbing and treating symptomatic group A strep pharyngitis and in household members, especially siblings, and introducing school clinics in geographic clusters to ensure that a whole group of schools would all have clinics, including the feeder school, the intermediate school. So then we were able to use this rollout from the government money to try and establish robust evidence for primary prevention of acute rheumatic fever first presentation in a school-based or community-based setting. So this is a map for the 15 years of rheumatic fever register before the clinics were started. And the areas that are highlighted, particularly on the right, Mangere, Otara and Manurewa, and then at the bottom there, Papakura. And this is where the school clinics were rolled out. So this is reasonably geographic succinct area in Counties Manukau District Health Board where clinics were being rolled out sequentially. So our idea was to evaluate in a geographically concentrated community intervention and demonstrate for the first time using robust methodology. We couldn't use an RCT, but the next best, to show that rheumatic fever first presentation could be preventable in a community setting, and we were using an oral penicillin, amoxicillin. So this school program that's been presented at this forum in other years is the Mana Kids program. It's geographically concentrated. Most of the high-risk kids in counties are in greater than 90% in school clinics, year 1 to 8, and the model is as I've outlined. It also is extended to other services. So our evaluation methodology is looking at first presentation rheumatic fever in a population of about 25,000 and 60-odd schools. And it was a before and after methodology because the clinics could be, were rolled out in a staggered fashion. It was a generalized linear mixed model. So this is the descriptive epidemiology, just to set the stage. The red arrow is 2006, and at the top there is the beginning of the program, 2001. So you can see approximately the eye of faith, about 50-60% reduction. This is a cumulative graph in the age group in question where the school-based intervention was taking place. And so we were able to show, using our model, a significant decrease of first presentation acute rheumatic fever in a statistically significant way. The rates dropped from 88 per 100,000 to 37 per 100,000 after 2 years of introduction of clinics, a 58% reduction. So this is actually a global first. The possible limitations, of course, are that it isn't an RCT, the gold standard if you like. It's a community intervention with all the things that go on in a community, but we believe that most of the kids were in a clinic and accessible to a clinic. There was very little extra GP activity as measured by the rapid response money that came out of the government as an extra. So it's a poor before and after method, and there were health promotion messages. So the take-home message, school clinic model is successful. It improves access. The implementing of a full clinic model is obviously the most important part of this, different to the RCT, and there is some economic evidence. And so I would like to thank many, many contributors over 15 or 20 years, but particularly Pip Anderson as part of the Mana Kids team. Thank you.